Hello, everyone, and welcome to the CoROM podcast. This is where academic medicine meets remote, austere, and resource-limited areas.
Welcome back to the program. This is Aebhric O'Kelly. This week, we are with Dr. Sean Bilodeau, who is an emergency physician working in Maine. He has joined our faculty of the Masters of Austere Critical Care. Sean, welcome to the program.
Awesome. Thank you so much for having me on. I'm really excited to chat.
So tell us a bit about yourself and what's keeping you busy.
I'm quite busy. So currently, like you said, I'm a ER doc in Maine in the U.S. I'm currently finishing an Emergency Medical Services Fellowship, which is an extra year of subspecialty training where I spend most of my time with the EMS crews, flight crews, doing field response as a doc, which is a little bit different from what normally happens here in the States, but it's a really great time for me to focus on something I really like doing some research with that. Before med school, actually, I was a nurse. I was an ER nurse for 5 or 6 years and then kind of decided to go back into training. And so I do a lot of education with nurses and paramedics and spend most of my time thinking about how we take complex medical problems and distilling it into what do I do at 2 a.m. on the side of the road.
So as we speak, you're currently on the side of the road, aren't you?
Yes, I'm currently on the side of the road. We got called for a patient, and it's just how it worked out with this timing. But I have a phenomenal group of paramedics, and I am just kind of hanging out with my doc bag, and I'm here if they need me. So if I have to jump off, I have to jump off.
So tell us how this works. Here in Europe, we have doctors in a box, doctors in a response car, pre-hospital, everywhere. And in the States, they're just not common. So tell us about how that is, and tell us why Maine is different.
So yeah, you're correct. Like the States has a very different model. Our EMS docs are all emergency medicine trained. So 4 years of undergraduate, 4 years of medical school, and then 3 or 4 years of emergency medicine residency, and then they do a subspecialty year of training in just pre-hospital medicine. At that point, after that, you become board certified in emergency medical services, and so you do medical direction. As a fellow, so like where I am right now, I do a fair amount of field response. But as an attending, meaning like once you finish your training, you do most of your time writing protocols and helping with education, reviewing runs. It's less sexy as flying in a helicopter as a doc does in Europe. It's a lot more administrative, but it does allow us to really look at a system of care as opposed to like a single patient, which is pretty interesting.
So we do have docs in HEMS, but the majority of our pre-hospital docs here in Europe is in a car.
Yeah, so I mean that's most of what our docs are doing is also in cars, but we have a couple flight programs that'll fly physicians. It honestly comes down to money, like most things, right? Like it is less expensive to have one physician overseeing a service versus paying them to go like an hourly rate sort of thing.
But it has to be fiscally responsible to have a lot of physicians pre-hospital because you can treat and release. Can't you save a tremendous amount of money by having a doc in pre-hospital?
So I think that in theory that's correct. Like you can treat and release. What ends up happening just with the litigiousness in the States is you spend a lot of time transporting folks because you're not totally sure exactly what's going on, given the limited things we can do in the pre-hospital environment. It is not an ideal setup, but is kind of like currently the one that we're working with. I think we're starting to push more of that here in Portland where I work is this idea of can we just treat and release or could we even treat and release from a paramedic, which is functionally like a community paramedicine model. And I think we're working towards that. It's just a lot of trying to figure out how that works in the current state model and the protocols.
So in a perfect world, let's say you are in charge of the pre-hospital system in the U.S. What would you want to change? How would you want to build this to be a better system?
I think really giving our paramedics the space to do exactly that, to like see the patient and work as a clinician, decide if they need transport or not. I think that there's so many barriers to that, and one of which is actually culture. Is this idea that I call 911, an ambulance comes, they pick me up, and they bring me to the hospital. And I think having patients or people in the community understand that that's not necessarily the best way to deliver healthcare. And I think a lot of times our paramedics are stuck with I have to bring them to the hospital because that's what they're expecting and that's what my protocols say. And so I would love to change that paradigm and say, like, we have these paramedics, which, at the birth of that was a street doctor, right? Like, you can assess patients, understanding that there's a broad range of things that could be happening, and you have the tools to treat a good number of those. But again, you need community buy-in for that too. It's not like our communities are saying, I want this, and our paramedics are the ones that saying, no, you have to go to the hospital. It's quite the opposite.
So you called the paramedics a clinician. Doesn't that mean that they should be under the Department of Health and they should have more training and possibly a degree?
So all of our paramedics do have a degree, and they go through a paramedic course, which is an associate's degree. So here in the States, so that's two years post high school. Um, I think that clinician, when I'm using that word, I'm thinking about a person that can independently evaluate, assess, and treat people. I think we use the word provider, and that's probably fraught with some medical legal problems. But what I'm actually asking for is a paramedic, is someone who can look at a patient, decide what the differential is, decide how to treat that person, and then decide a disposition, meaning hospital or home, within a limited scope, because we're not talking about someone who went to med school for 4 years and residency for 4 years, et cetera, if that makes sense.
It does. And here in Europe, it's a 3-year bachelor's degree program for the paramedics or ambulance nurses, depending on what you call them. And they have their own license. They're practicing as their own provider, or sorry, clinician. Why can't the US do that?
So the U.S., our medics do have their own license. So every paramedic is licensed at the state level in which they practice, and they also all or almost all are licensed at the national level. I guess they're certified at the national level through the NREMT, which is our giant group that um, does the that accredits paramedic courses, and then everyone gets a state license. And so this idea that a paramedic works under a physician, which I think is what you're getting at, Aebhric, is true in that the physician signed a protocol that allows the paramedic to function within that protocol, but it doesn't handcuff the paramedic to say that they can't make independent decisions. And the corollary there being, like, let's say a paramedic does something egregious. That's not on the physician that wrote the protocol. That's like the independent agency of the paramedic that made the choice, if that makes sense.
Yeah, it does. Um, so here in Europe, a ambulance nurse or paramedic doesn't work under a physician. They like in Ireland, the advanced paramedic will take his medical bag, including narcotics, home at night, and he's always able, he's always on. If a neighbor knocks on his door saying, "Hey, I broke my leg," he's allowed to practice and give drugs under his own remit without having to be under a medical oversight. Does that make sense?
Yeah. Yeah, it does, and I know that's very similar to the Canadian system. It's actually very similar to like the U.S. military and special forces world. Those medics take their drugs home and they treat folks. It's usually kind of limited to the patients in their battalion and their platoon, but or not patients, the um, colleagues, but they have their stuff at home. Currently in the state of Maine, the individual paramedic is not credentialed. It's the service that is credentialed. So a paramedic is licensed, but not to practice independently within their scope. However, you need to be attached to a service that is credentialed. And so that gets into this, like, that's why we don't have paramedics with drug bags at home. And that's just the way that the system was set up from a credentialing standpoint. My personal take on that is that our paramedics are capable of doing what is happening in Europe. It's just not currently the system, and so it takes a long time to make culture shift and push towards more independence.
Yeah, fair enough. And to be fair, the U.S. Was one of the first to have paramedics, and they've been doing it a very long time.
Yeah, and if you look at, like Pittsburgh in the late 60s and 70s, that was that's not the first, but one of the most progressive paramedic systems in the States. And they were doing all sorts of things. That was unfortunately fraught with racial tension because they were only doing it in places that the white paramedics didn't go. And so, there's a long history of that here in the States, where you have all these kind of different practice patterns in different areas depending on where you work and who you work with, right? So if you work in the Indian Health Services, you have a different set of rules than if you work for the state in which the person lives, right? So it's all very complex.
So you're going to finish this EMS fellowship. What's next for you?
So I am gonna stay practicing in Maine as an attending ER doctor. I'm also gonna do some medical direction with the fire department I work with now. With a kind of short-term goal, we're kind of playing around with the idea of paramedic induction of Suboxone, which is happening in a couple different places in the States, but not in Maine. And so we're kind of tossing around this idea of, can we make this work? And then gonna stay on, or I just recently joined the College of Remote and um, Offshore Medicine to help out with their master's program and really kind of focus on, for me anyways, thinking about education in the austere pre-hospital space and the overlap between that and critical care.
So yeah, you've joined our faculty, and you've taken over the 702 module of the Austere Critical Care Master's Program from me, and you're running that now. But what are your plans? What would you like to do with CoROM?
So I really want to look at this educational institution as a way to further like research and advancements in the pre-hospital space. Currently working on a research project thinking about how do we teach paramedics to do needle decompression and finger thoracostomy, and not necessarily the skill itself, but the anatomical landmark location. And as I've moved through this, I keep thinking about ways that we can use these larger educational institutions to kind of solve some of these bigger educational problems that are really hard to figure out on a smaller scale. And so I'm hoping to use that space here with CoROM to be a part of a larger institution and use that networking of folks that are teaching paramedics and all in Europe, Australasia, here in the States, and kind of try to figure out how to optimize the educational system, particularly for these high acuity, low occurrence procedures that everyone is trained to do, but no one is trained to do them the same way.
So are you going to be looking at this as a systemic level of paramedic education or individual skills and tasks?
So, I mean, the lofty goal is to look at the system, right? Is to understand how to educate an entire profession on a very high acuity skill set. That is a career level goal, and so probably we'll start with a lot smaller thing of how do I teach my group that I work with to optimize what they're doing.
So it sounds to me like you're looking at a global association of EMS educators as a group to get a big picture look on this at the global level.
Yeah, I mean that is as big a goal as you can get, I suppose, Aebhric, right? Like the idea that we could all talk across international borders about the same things that we're doing and figure out how to best do it together.
So you're already sitting on the board of what is it, Wilderness EMS National Association of EMS Physicians.
Yeah, so I mean I'm not like high up on the board. I do I like am part of the National Association of EMS Physicians, which is our big national group. I help with their like wilderness piece. So definitely, I'm not like on the board of that. That is just something I'm helping out with. A lot smaller than it sounds.
But is that something, that model is what you're interested in, but on a global scale?
Yeah, I am, and I think that the thing that CoROM brings is that you have this network of people that work in different environments across country lines, and I find that we get so pigeonholed here in the States about here's what I do in my state, here's what I do in my country, and then in just spending time with CoROM and doing some of the courses and meeting people that have the same exact problems in Poland or Canada or Hungary, and they're approaching it in a different way. And I think that allows us to really brainstorm and come together as like, oh, I found this particular way of teaching works, and or even, hey, have you thought about using different vasopressors, right? Like stuff that we don't think about because you get so like tunnel visioned into what you're already doing because that's what you've always done.
Are you looking at this as your master's thesis?
I mean, hopefully, I was going to start with looking at how to teach finger thoracostomy, but it just keeps getting bigger and bigger and bigger. So I think that is now what started as a simple research project, which has grown into possibly a master's thesis.
Nice. I wouldn't have thought that needle decompression would have been that contentious.
No, and I think what ends up happening is that everyone's taught this thing, right? Like everyone is taught how to decompress the chest in paramedic school, whether you're in the States or Europe. And everyone is taught in a different way. And it wasn't until we broached the question that someone came and said, why don't we do finger thoracostomies? And then we started looking at the data, our cases, and we said, wait, how can we do finger thoracostomies if we're anatomically not hitting the right place? And then that grew into, why aren't we hitting the right place? And then it became, oh, we're not hitting the right place because we don't train the correct way. We give everyone a standardized dummy of just the right side of the chest with an insert, and everyone puts the needle exactly where the person put the needle before them. There's a poke mark there. We don't go into the cadaver lab. We don't have people doing this stuff in the hospital on a regular basis. Like certain programs are doing that, but it's not universal. And so it's not it's not a skill problem, it's an education problem. And that when you broach it that way, you think, yeah, this is a systems problem. And if there's other systems that are doing it in a different or more efficient way, we should talk to them. And then now we're talking about global community of paramedic educators or even just pre-hospital medicine educators.
So on this side of the pond, that conversation has been going on for a bit, and we're already binning the idea of a needle decompression anywhere, even mid-axillary, and we're just doing with a finger sweep.
Right. And I think that is a relatively new idea here. Um, but then I, did some of the courses with CoROM. Was like, wait, we're doing this. This is a cutting edge skill in the U.S. that physicians are doing. But well, actually, paramedics are doing it in other places. And to be fair, like some systems are doing that in the States. And you think about like San Antonio or Seattle. A lot of our critical care services are doing it, but not the like standard municipal service that where most people live, right? Like we don't have the same education whether you're critical care or not, and so I think we really need to improve that education and skill set for people that are taking care of the majority of the folks in your own hometown.
I can understand the pushback from the U.S. side because you as a doc, so you're going to let me as a critical care paramedic finger sweep it, but I mean, chest problem. So chest injury turning into a breathing problem takes 40 minutes. So I'm guessing your argument would be just take the 10 minutes to bring him in the hospital so you can do that. Is that right?
So that's the standard paradigm, and that's what I really want to flip on its head, Aebhric, right? So that's the idea. The answer of just drive to the hospital should not be an answer for the majority of things. Certain things, yeah, a traumatic arrest, a STEMI, or stroke, these time sensitive things, yeah. But if we're talking about 10 minutes, like we know that decompressing the chest, if you do it within the first 5 minutes, is better than the last five, right? So as soon as possible. So I don't want the answer to be just drive to the hospital so the doctor can do it. I want the answer to be, I'm so well trained, I feel comfortable that I can assess, diagnose, and do this procedure before I get to the hospital. And we're seeing stuff like this with STEMI, and it's not a procedure, but we know that if you want to get door to balloon in less than 60 minutes, you're not doing that without a functioning EMS system that does an EKG, interprets it, pre-calls, gets the aspirin on board, gets an IV, gets them on pads, right? Like, you can't do that without the EMS system. And so I think the drive faster is not the right answer most of the time. And I think that is unfortunately where we're stuck, because we think, oh, just have the paramedic drive them in. Like, no, I think we should optimize the paramedic skill set and give them the confidence to do the stuff that they know how to do and not worry about, I need to get them to the hospital faster. I need to do the critical intervention while also going to the hospital. You know, we see it in blood too, right? Like, the idea that you need to wait an hour to get to the hospital to get blood. Like, we know that blood needs to be given in the first 15 minutes if possible. I can't get most patients from a traumatic injury to the hospital in 15 minutes, even in an urban center, right? And so we need the paramedic or the pre-hospital provider to be doing that.
Yeah, I think, I mean, you mentioned blood. Let's go ahead and talk about the elephant in the room. So that's an easy answer. Like blood needs to be pushed forward. And the TCCC committee is relooking at March algorithm to have blood in M, massive hemorrhage, because they feel it's that important to start that pathway of getting blood on board.
Yeah, exactly. So, like, we should we should have blood, right? Like, that's the research was done in the conflict zones. Like, we know that early blood is better blood. We know that we shouldn't be giving pasta water to people who are bleeding, right? Like, we know we need to give blood. The problem comes with logistics and operation. So how do I get blood from a hospital to a patient? Okay, well, what if I put the blood at the EMS station? Okay, how do I keep that blood cold? How do I monitor it? What happens after 28 days when we need to trade that blood out? Do we just throw it away? Do we give it back to the hospital? Do we have a rotation schedule every 2 weeks? And so it's all of this sort of thing. And we know that blood is a very precious resource, and we want to make sure that we're not wasting it. So how do we effectively store it, deliver it to patients, but without wasting it? And so that's where the hangup is. I think the issue about whether we should give it or not, in my mind, has been solved. The answer is yes. It's just, how do we do it?
So let's look at what you're doing. You are the EMS director, Sean. Do you have blood for your paramedics?
So we currently don't have an active blood program. We're in the process of working on that, especially as there's a large focus at the national level in the States about improving trauma care, and blood is one of those things. So we're currently in the process of, we have a vehicle, we have a fridge that's spec'd out that is approved by the blood bank to store the blood. We have a way of monitoring temperature. We have a way of delivering it with a warmer. We're just figuring out the availability of that resource, if the physician is on or if the paramedic is on. And the other thing is, what is our like replacement schedule? So is it every 2 weeks? How are we going to utilize the blood bank and make sure we're not wasting that resource? So that's where we're in the planning / enacting phases of that right now.
So it sounds like you've already done the hard part. You've got MICU blood warmers. You've got trained up personnel. You just need physician approval and the blood bank approval to make this happen.
So the latter is the big one, right? So, like, the blood bank approval is challenging, and I think that speaks to the frugality of the blood bank system, which is really important, right? Like, you have this resource that is not infinite. We need to make sure that we're taking care of it. But it also speaks to what is a just general, like, black hole in most people's minds about what pre-hospital medicine is. And the number of times I've had to talk to people about, hey, you're injured. There's not just a teleporter that brings you to the hospital, right? Like, there's a time that happens there. There's an intervention that happens there. There's assessments that happen there. And I think sometimes getting people who don't live and work in that environment to understand that we have 15 minutes, there's a lot that can happen in 15 minutes. Whereas sometimes in the hospital, you think, well, 15 minutes, that's a fudge factor, right? Like, there's like that, we do stuff that could be plus or minus 15 minutes all the time. Whereas blood in the field, there's not a plus or minus there. Like, we need to do that fast. And so it's getting people to understand that. And I think the waste thing, we need to make sure that we're being efficient with the use, because as soon as we start wasting blood, that's an inefficient system. We don't have enough blood to waste. And so we want to make sure we get it correct the first time. And we're seeing programs do this. Like our critical care service here in Maine has blood. Their critical care service I worked for in Rhode Island, they have blood now. A lot of our bigger systems like San Antonio, they have blood. And so it's going to happen. We just got to figure out how to make it work for our particular system.
So you mentioned a fortnight. You mentioned 2 weeks as a rotation. Is that the best option?
It's hard to know. And so I think the issue is, like, if you think about whole blood, you have 28 days or so, right? That's how long that's good for. If I wait till the 27th day and return it to the hospital, what are the chances it gets used today? And so maybe the 2 week system is a way to say, like, we'll keep this unit or these 2 units for 2 weeks. Every 2 weeks we trade it out, because that gives you another 2 weeks in the hospital to use that. A little bit longer with pack cells, and so maybe the rotation there is a month. But the same idea holds true. You want to make sure you can get it back to the hospital with enough time that it can actually be used, because returning a unit of blood that's going to expire in 24 hours is of no use to anyone.
You're a fellow of the Academy of Wilderness Medicine. You're big in wilderness medicine. You're on the board of National Associations, the EMS is Wilderness Medicine. Let's talk about these two things. So we're talking about finger sweep and blood. How is this going to work within wilderness medicine? Is it just blood products because they last longer, or what's the option? What's the future?
So I guess you want to talk about blood in, like, wilderness. I think when I think about wilderness, especially with my work with CoROM, I'm thinking about, like, austere medicine more. So yeah, like, I'm thinking about the humanitarian disaster. I'm less thinking about Everest Base Camp. The logistics of giving someone blood on Everest Base Camp are probably insurmountable where we're at right now. But in terms of, like, doing disaster medicine, yes, like, you need to give blood and look at this in like conflict zones, right? So I think we're down to just figuring out how, like, logistics and technology work together to do the thing. There's an idea, like the walking blood bank, right? Like, that's doable in a small group of people. I have read a little bit about, like, larger groups. So thinking about, do we have, like, a whole town or whole community that we know people, we have donors in that community that have been pre-screened, or and then have, like, consented. Like, that's an idea too. Again, like, logistically, how do you pull that off? And especially in a disaster or in an austere environment where you don't have maybe communications and all, like, the resources that you have. So the blood seems to me harder from, like, a wilderness austere standpoint. And again, it's logistics. Maybe you're lucky enough and you're injured with the person and you have the same blood type. I don't know, like, that's a hard one to kind of work through, if that makes sense.
Yeah, the walking blood bank is good for a very small community, but for a larger scale, it's just not going to work.
Right. Yeah. And I've heard of ideas like everyone who's under 14 gets blood typed. The idea being that, like, your risk of HIV and Hep C are a lot lower in the younger group. But then you're talking about blood donations from minors. And so it is fraught with logistical headache.
So, do you think blood products would be the only option then, such as shelf stable options?
So no, we know that FFP works, and there's currently freeze dried plasma that's not FDA approved in the States. And so I know about freeze dried plasma only from research studies and chatting with some of the special ops groups that are hearing about it, or maybe getting a hold of some of it. I think you guys have that in France, or not. I know, so you're in Ireland, but I think Europe has that in France, if I understand correctly.
Yeah, I was on the Swedish HEMS. Definitely had it there as well.
Yeah. And so that's shelf stable for like 2 years, I believe. It's dried, so you don't have to worry about heat and moisture, and it's vacuum sealed. It's in a glass container, is my understanding. So there's some issue with that, but that might be, the future. And I believe, don't quote me on that, but I believe it is going through FDA approval. It's just not, I don't have access to it now. And that might be an answer, right? I don't think we have all the data on that right now, but it totally is an option.
So that's blood in austere environments. What about the finger sweep and the needle D?
The finger sweep, I feel like, is the way to go with this. Again, if you can effectively teach people the correct anatomic landmarks, um, the finger sweep really it gets rid of all these logistical headaches after putting in a needle D, right? So you put the catheter in, how many of them back out, how many of them kink. We have some good CAT scan images of the needle that was probably through the pleura, but then has now backed out. And so the finger thoracostomy is so much more efficient in that you create a large enough hole, it's not going to clot. You put a chest seal on it, and then you burp that. And then, hey, if it gets stuck, you put your finger back in it and open it up again. I know, like, in the event that I was in that plate in a scenario where I had to do that, the finger would be what I would do, and I would monitor it. I wouldn't be stuck looking at this catheter and saying, "Oh, is it clotted? Can I hear the air coming through it?" Like, no, you put your finger in and open it up, and then be kind of done with that. It requires it. What I'm learning is that it requires an interesting skill, which is scalpel to skin. As a physician, that's not a thing I think about a lot. But when I work with the pre-hospital providers, we don't do a lot of things that are scalpel to skin. We think about this we think about it with crikes too, right? So the act of cutting the skin with the scalpel is relatively foreign, and so there's some amount of cognitive blocking that happens there, where you feel like, oh, I'm cutting this patient open, even though cognitively you're like, yeah, I know that's what they need. But there's something different about scalpel to skin, and I can't articulate it better than it's just an experience that most pre-hospital providers don't have, or a lot of, or feel comfortable doing. And we see this with junior docs too, right? Like the first couple times you stitch, or the first time you use the scalpel, is always nerve-wracking until you get used to that. And I think it's the finger thoracostomy, the cricothyrotomy, it brings up that idea too. The scalpel to skin is an interesting concept that we can train through. But that, again, so in an austere environment, my personal take is the finger sweep is the way to go with that. Just knowing you have to monitor it.
Yeah, and it's not even talking about the training and the upkeep and the CPDs and having the physician oversight for the U.S. paramedics to do this.
Yeah, I think I think that the physician oversight part is relatively easily overcome in a progressive system with good enough training. And I think that we're talking about that here, looking at maybe we just remove the needle decompression and go straight to the finger sweep, which is kind of what you and I spoke about earlier. That is a singular skill set that you can totally teach. You can QA, QI, and you can show that that's going to be safe, as we all kind of intuitively know it is. Like, it passes the gut check, right? Like, there's no needle going towards the heart. It's a blunt finger. That's much better.
So, Sean, my final question for you is this. What advice do you have for the new doctor, new nurse, new medic who's just starting out in their career in austere medicine?
So I guess what it's going to come down to is this field I'm learning is you get out of it what you put into it. And it started with hey, I got to go to Chamonix and do an advanced wilderness life support course because I funded by my residency program. And then I met some people, and then I kept going with the FOM, and then found CoROM and did an eye care course and was like, wow, this is a world I didn't even know existed. And then you start talking to people and asking questions and getting involved and asking to help out. And there's more than enough projects, and you put your time in and it comes back tenfold. And, I just got back from speaking at the Medicine in the Mediterranean conference, and it was like the highlight of my year, but what I feel like is the jumping off point of my whole career, and the folks I got to speak with and stuff that I got to see, and knowing that I can just email these people and get involved. I think if you want to be involved in this, just jump into it and don't be afraid to ask, hey, is there a project I can help out with? I mean, Aebhric, put my email on there, man. Like, I got lots of things that if people want to help, I have lots of projects and not enough time. And so I think, it's about what you put into it. I think thinking that you're going to just show up, and become a physician on a search and rescue team, or you're all of a sudden going to be in the Antarctic or at Everest Base Camp or, Nepal, whatever, without putting in the work is naive. Like, you got to put in the work and make the contacts and show that you're interested. But if you put in energy, it just comes back.
Awesome. Is that you having to go? Is that a call?
No, that was just someone ringing the doorbell. Sorry, man.
No bother. Brilliant. So if any listener is interested into talking to Sean Bilodeau, you can send an email to info@corom.edu.mt or s.bilodeau@corom.edu.mt. Common spelling. So, Sean, it's an honor to have you join our faculty, and I am thoroughly looking forward to seeing what you can do within our program and also what you can do with pre-hospital physician-led EMS.
Awesome. Yeah. Thank you so much for having me. I'm so excited to be here with you now, but also just to be a part of CoROM, and like this whole world has opened up, and I'm so excited that I get to kind of walk through that with you all.
This has been a presentation from the College of Remote and Offshore Medicine. If you would like to earn CPD credits for this podcast, you can join the Council of Members. Being a member of the college gives you free CPD credit, free access to our virtual field guide, and discounts on our e-learning courses. You can join the team on our college website at corom.edu.mt.